Hi, welcome. My name is Julie Heffernan, and I work at the ARC of Massachusetts. I wear a few hats there, but today the hat I'm wearing is project manager of the Dana Home Foundation / support brokers grant. And I know that there are a few people from Lexington in the audience, but I know that there are a lot of you who are not from Lexington. So I'm going to give you a quick little recap of the Dana Home Foundation. But in 1905, the Lexington Home for the Aged was established in Lexington. It was one of the first care facilities for seniors who were no longer able to take care of themselves. In 1916, there was a big fundraiser, and a lot of folks in the town donated money, particularly Ellen Dana, which is how it came to be known as the Dana Home. And it continued for almost 100 years, but then supports in the homes were on the rise, and so there was really no longer a need for the Dana Home Foundation. And so they sold the building, but they took the money and they put it into a foundation. And true to the mission of the Dana Home for the Aged, they award, every year they give out grants, I believe they're anywhere from $3,000 to $50,000 to agencies and groups that support people, the aging population. And so we at the ARC of Massachusetts have been very fortunate to be awarded a grant the last 2 years, and our grant is specific to supporting seniors with disabilities in Lexington. And in fact, last year it was even more specific than that. Last year our grant was to support seniors with autism in Lexington. And last year our cutoff point, we started at 50. We thought aging with autism in Lexington. This year we've expanded the program a bit, and we are serving 5 adults with autism and or intellectual disabilities, and we've dropped the age to 45. So I say all of this to let you know the program that you're listening to, but also we still have a couple spots. So if any of you, and I know many of you work with this population, if any of you know of someone 45 years or older with autism or IDD and living in Lexington or with a strong connection to Lexington, please give us a call. I have my cards, and we would love to talk more about that individual or individuals. Okay, so that's the background here. The other thing I'll say is that in addition to working at the ARC, I have 3 children. I have a 27-year-old, a 24-year-old, and a 22-year-old, and my 27-year-old, the one who made me a parent, has Down syndrome. And so I am here not only in my role as the ARC, but I'm also here as a parent. And I will introduce you one by one to our speakers. We're so lucky to have such a wonderful team. And some of you probably know Dr. Neumeyer already, but she is over here standing against the wall. And I have your highlight reel right here. It's only a couple of things that I'm going to mention. But she's the medical director at the Lurie Center for Autism and an assistant professor of neurology at Harvard Medical School. So she has 20 years of experience diagnosing and caring for children with autism spectrum disorders. Co-founder, co-director of the first Phelan McDermott Clinic at the Lurie Center, and is really focused on improving the lives of people with ASD. Coordinates autism programs with other clinical and research programs. She was appointed to the Massachusetts Governor's Autism Council Subcommittee for School-Aged Children, and she's a member of the steering committee of the Autism Treatment Network's Autism Intervention Network on Physical Health. And so she studies also. She studies children with autism, lots of research, including, I think, bone density, bone issues. So anyway, with that, I'd like to introduce Dr. Ann Neumeyer. Thank you for coming.
Well, thanks for having me here, and I'm going to try to keep to my time. So I work at the Lurie Center, which, if you're from Lexington, we're across the street from the dump. And if you're not from Lexington, we're over on the other side of 128 in an office park, so on McGuire Road. And we set up our clinic out there. We're a Mass General clinic, but we specifically set up, apart from the hospital, we wanted a 1-story building so that it would be an easy place for people to come to. And if necessary, we see patients in the car sometimes, because there's a lot of anxiety. So because I work at Mass General, we always have to state our conflicts, so I'm on the Scientific Advisory Board of Speech Therapeutics. And I I think I'm going to actually skip over this slide, except to say that, as you know, autism spectrum disorder is a developmental disability, and there's no real lab test for autism. I do sometimes now see adults who come in with autism who've never had appropriate genetic testing, and we are finding that some of these adults do actually have genes that are associated with autism, and that can sometimes be very helpful, because if we know you have a specific gene, then we also might know that there's associated medical conditions that are seen with whatever the gene is. And so that could be helpful for caring for the person. And the other thing to know is that there are a lot of genes, including Down syndrome, that are associated with a higher rate of autism. So the important thing, I think, to know is that we actually don't know very much. So there was a working group on autism spectrum disorders in older adults, and they wrote, "Little is known about the phenomenology and associated features of autism as individuals age. We don't know about the underlying neurobiological changes, the changes in the brain, and about specific medical, psychiatric, and social service needs, including the need for long-term care." So the world of aging adults with autism is actually not well known. Not many people study it, and so I guess the positive is that there's a lot of work to be done, and it's an open area for people to do research, but the negative is for people who have aging siblings or children, we just don't know that much yet. So important numbers, 1 in 68, or 1.4% of the population of the United States has autism. It's 5 times more common in boys than girls. In Massachusetts, there's 18,000 students between the ages of 3 and 22 in public schools. There's more in private schools, but we don't always have those numbers. And in 2011, there were 24,000 adults with intellectual disability over the age of 18 that were served by DDS. So how many of those have autism? We don't know. 500,000 children in the United States will become adults with autism in the next decade, and they're going to need medical, dental, vision, preventative screening, and psychiatric care. And basically, we're not well set up for that. Physicians, dentists, nurses, ophthalmologists, optometrists aren't really well trained in caring for people who can't express themselves verbally very well. And so that's a big challenge. We do know that adults with developmental disabilities and diabetes are screened less frequently than task force guidelines recommend. Women have lower rates of breast cancer and cervical cancer screening. It's very hard for a woman who can't communicate well to have her have a pap smear. And that rate is even lower for those people who are living at home as opposed to outside of the home or in a group home. The rate of colonoscopies, we don't know it, but we know it's too low for adults. I hope I'm not talking about what you guys think. Okay, so what we know from children in autism and adults, but mostly from children, is that there are a lot of medical conditions that are associated with autism. Difficulties with sleep, seizures, GI disease. I'm going to talk a little about pain, ear, nose, and throat, vision, bone, obesity, and psychiatric comorbidities. I always start with sleep because sleep is so disruptive to everyone in the household. And people with autism have disorders of falling asleep, staying asleep, and waking up too early. And those are, of course, due to core deficits in behavior. Changing from awake to sleep is hard. People with autism and also developmental disabilities often have lower amounts of melatonin, and melatonin helps you to set up your biorhythms and to feel sleepy, and so if you don't have enough, you don't feel sleepy. We have people with autism and intellectual disabilities, but more so autism, have a lot of comorbid illnesses, so gastrointestinal disease or epilepsy. Sleep apnea is very common in children with autism, and we don't yet know about adults. So if you're not sleeping, you're more irritable. If you're more irritable, you might look more autistic. I'm more irritable if I don't sleep. So everyone's more irritable, and that's not the autism, it's the sleep. And so I think that's always very important, is when somebody starts to look more autistic or more irritable, that you have to look for something else. So the first thing I always ask about is sleep. And you should inform your family members' physicians about, or be aware of sleep issues as you bring your person that you're caring for to the doctor. So for treatments, there are medical treatments, but probably the most important things, and one is on here and one isn't, is that ensure that there's no medications that are impairing sleep. No caffeine, and then the stimulant medications like Ritalin and Adderall, those all make it harder to fall asleep. And then the other thing which should be on here, but it's not because it's not medical, but is exercise is really, really, really important, because that helps you to establish your biorhythms, and it takes away stress, and it makes it easier to fall asleep. And if somebody's doing nothing all day long, it's harder to fall asleep. And then we have medicines, and melatonin is something that you can get over the counter, and it's short acting and long acting. And that can work well, and I don't think you need to go to a doctor to try that. And then the other medicines, except for Benadryl or diphenhydramine here, are medications you need to ask the physician for. And then the other thing to remember is there are other conditions that cause difficulties with sleep. And so anxiety is really hard to fall asleep if you have a lot of anxiety. And if you have reflux, gastroesophageal reflux, what happens when you lie down? It gets worse. So when you go to sleep, it's going to get worse. And so that always needs to be treated. Okay, so autism in epilepsy is very common. The rate's 3 to 46%, depending on which study you look at. I usually say about 25%. But there's no one seizure type that we associate with autism. There's no specific EEG waves that we see. And it generally comes on in two groups, the group of children under the age of 5, and then the second group is in adolescence, when they start to have seizures. And some people do outgrow seizures and some don't. And there's no one special medicine that we use for autism over any other. So gastrointestinal disease is really common. So we have a GI doctor at our clinic that we brought out because we realized there's so many children that have GI disease, and it's a friendlier place to go to our clinic, so it's more like a one-stop shop. And we see a lot of chronic constipation because a lot of people with autism have kind of more relaxed muscle tone, and the muscle tone extends to the tone in the gut. And so if the gut tone is a little low, you're more prone to constipation. Reflux also, and then there are other conditions like inflammation of the gut, eosinophilic esophagitis, and pancreatic insufficiency, and irritable bowel syndrome, and inflammatory bowel disease. and nutritional disorders. And nutritional disorders are really, really important because a lot of people have very restricted diets. They won't eat certain foods, and so it's very important that that vitamins are given to make sure that you're not vitamin C deficient or vitamin D or other vitamins, and so it's very important that that's addressed. And a dietitian is a good person to see to make sure that the diet is appropriate. Okay, so I feel often in my work that I'm a detective. And one of the reasons is because people who aren't verbal don't just say, I have pain, and they express it differently. And they may not even tell us what hurts or where it hurts. And some people might vocalize. They may have body movements like pushing their bellies or leaning up against something, or having a facial expression, or increasing self-injurious behaviors, or becoming aggressive. So those are all what some people might say are signs of autism, but in reality, a change in those signs might indicate that there's a pain issue going on. So that's very, very, very important. I had one young man, mother told me just yesterday, he kept talking about the doctor, and every once in a while he would pull on his ear. And sure enough, he had an ear infection, but he didn't say he had pain. He just mentioned the word doctor, which was very unusual for him. And so you have to be a detective. And I always say, remember, behaviors usually have a biological basis. They are often due to change or anxiety or pain. And I think I'm going to stop this slide. So ENT issues I mentioned before. We have a higher prevalence of sleep apnea in people with autism. And CPAP, that device that you wear, can be very, very difficult for someone who has autism to wear. I do have one young man who tolerated it because his mother incorporated it into a Darth Vader mask. And that was a very strong interest of his. So you have to be creative. But in reality, sleep apnea, as many of you know, aside from daytime fatigue and not sleeping well at night, you can end up gaining weight and really losing cognitive function. And so it's really important that that you think about that. Okay, so my interest is in bone, and we have learned that children and adults with autism are at risk for osteoporosis or decreased bone density. And one reason might be that they don't have enough vitamin D, and we've listened to the dermatologists and we slather ourselves with sunscreen, and therefore we don't get as much vitamin D from the sun as we used to. A lot of people aren't drinking milk, and up until recently, a lot of the soy and almond milks didn't have vitamin D added to it, and so people just weren't getting enough vitamin D. So vitamin D is important for bones. And then we don't exercise. People with autism don't exercise as much, and the act of walking actually strengthens your bones, and jumping strengthens your bones. So exercise is really important for bone development. So we looked at emergency room admissions in a big kind of database of emergency room admissions across the across the United States, and what we found is that there were a higher rate of spine fractures in women between the ages of 23 and 50 with autism than typical women, and that there were a higher rate of forearm fractures and also hip fractures. In young boys with autism, they don't have as many fractures as their counterparts, probably because they're not engaging in all those risky behaviors like playing football and doing other silly things that adolescent boys sometimes do.
Dr. Neumeyer, there are about 5 minutes left.
Perfect. So obesity is another common problem. Adolescents with autism and Down syndrome are 2 to 3 times more likely to be obese than the general population. Part of that might be because they're inactive. They take medicines that cause weight gain. All the atypical antipsychotics cause weight gain. And often we have, unfortunately, used food as a reward for behavior. Early on, that's okay, but you have to change it over to something else that's rewarding. Otherwise, you're going to have a big problem with food and weight gain. And then the high carb diet. Okay. So I'm going to skip through these. And I want to show just a video of one young woman who presented to us with a problem because she couldn't talk and communicate. I hope it works. Let's see. What's that? So she had some strange movements. Whoops, let's see. Okay, it's not going to work. I can tell. Well, we see a lot of people. This young woman was having very bizarre movements that looked like seizures. She'd drop her head, and then she'd hold postures and shake. And it turned out that she wasn't having seizures, but she was in fact having reflux. And reflux pain can, in little babies, they'll often have a funny movement and they'll arch their back because they're in pain. And adults who aren't very verbal will sometimes do the same thing. And so the whole point is that strange behaviors in autism are often medical problems. And that you have to think of the medical and not just use a psychiatric medicine to solve the problem, because it won't solve the problem. It might suppress it, but it won't solve the problem. So at Mass General Hospital, we have instituted an autism care questionnaire, and that is also used for other people with disabilities, although the name was designed for people with autism, and it's to inform the doctors, the nurses, the technicians in the hospital about the language and communication abilities, as well as the sensory issues and fears, and what somebody can tolerate before they go into the hospital. So the family fills out this questionnaire, and then we know when they're coming into the hospital what to expect. Can they wear an ID bracelet? Are they going to bring their own pajamas? Or, can they tolerate a hospital gown? And is someone going to need to have a signboard with them? Or do they have an AAC device? Something like that. So that's been very helpful. And in the past year, we also have brought on an autism coordinator, and this is an occupational therapist who will help coordinate hospital admissions for people who either have autism or an intellectual disability and poor language or communication skills. And that's been really, really helpful for our staff as well as for the families. So, Lurie Center. We're a multidisciplinary clinic for children and adults with autism and other neurodevelopmental disabilities. And so we have neurologists and psychiatrists, developmental pediatricians, gastroenterologists, geneticists, neuropsychologists, nurses, family support, and education consultation and behavior consultation. And I guess it's hard if you're alone trying to care for somebody with multiple needs, but when you've got a big team working together, then it's kind of fun. So, I have some resources listed here, so when you get my slides, you can look at them. You probably know them, but if you don't, they're there. And all questions are good. So later on, if you have questions, I'm happy to answer them.
Thank you.
Thank you.
Do you know how to switch it to your computer? Okay, so you're going to try. So what we're going to do is we are going to take questions at the end. We're going to let our three speakers speak first. I should mention, I didn't even ask as we were settling, I do want to know, how many of you here are parents? Okay. How many of you are parents with a child on the autism spectrum? How many of you are parents with children with Down syndrome? How many of you are parents with children with disabilities other than those two categories? Okay, great. And how many of you are professionals? Wow. All right. Now, here's the question. How many of you wear both hats? Siblings. Siblings, also another good question. How many of you have siblings? Wonderful, wonderful. Okay, so the other thing I meant to mention in the beginning is over here you'll see we have Lex Media filming this. And Julie, we have a lot of Julies here today. And I'm Julie, this is Julie filming this for Lex Media. And if she gets it edited right away, which she thinks she has a shot at, it will appear next week. If it takes her a little longer to edit it, it will be available in 2 weeks from now. So if you have questions about that, if you're a Lexington resident, you can certainly ask Julie afterward. And I also want to mention, I don't know if you all know this, but this is being live streamed right now on Facebook, on the ARC of Massachusetts Facebook page. So we're trying to get this word out to as many people as possible. And then the last bit of housekeeping that I'll say, Dr. Neumeyer mentioned this, but we are going to make the slides available to you afterward. So what you do see here, if you're interested, we can certainly provide you with them via email. Oh, is that?
No.
She said press the HD.
Yeah, I tried it.
All right, I'm going to run down and get her. So, okay, Carrie, okay. So we're having a few technical difficulties. So why don't we make use of this time? And if there are any questions at this point, yes.
Yeah, I have 2 questions.
So sorry about this, Dr. Neumeyer. I'm afraid you're the one who's getting asked the questions. Oh, we're trying to, since we have to ask for technical help, we're going to fill this with some questions, if you don't mind.
So your slide about obesity is 2 to 3 times more likely in autism and Downs. Is that if you have both of them, or if you have one or the other?
One or the other.
So autism, you're 2 to 3 times more likely to be obese?
Yeah.
And my other question is, you talked about adults who you saw their genetic screening, gave you some hints. Do you recommend that all people, adults, children, get some kind of genetic testing? And if so, what sort? And is it covered by insurance, or is it something more sophisticated than that you recommend?
No, so especially for people with autism and an intellectual disability, there's a couple tiers of screening that we recommend. And the first tier is that for boys it's Fragile X and microarray. And 12 years ago, or even 10 years ago, even 5 years ago, I'll say, the insurance companies wouldn't pay for microarrays. So now they're paid for, and some companies will even do it with a buccal smear. So it's just, a cheek swab, like the 23andMe. And so Mass Health even covers it now. So I recommend that for everyone. And there is more sophisticated testing beyond that. If we have certain hints, we might use one test versus another test, depending on how the child looks, their head size, and many other factors. And then there's this whole exome sequencing, which can be done, and that's quite expensive. Sometimes insurance will cover it, but most of the time it still won't. Hope that answers it.
Okay, so thank you, Dr. Neumeyer. So we are ready to move on to the next speaker. And this is Dr. Stephanie Santoro, and she's brand new to Massachusetts. So I thought this would be a great way for you to learn about her and what she has to say, and also for her to get to know some of the folks in the Massachusetts disability community as well. She moved here in July, and she is the Director of Quality Research for the Down syndrome program, Down syndrome clinic at Mass General Hospital, and she also is a clinician who serves both pediatric and adult populations. But before she moved here, she created the Columbus, Ohio Down syndrome patient database, and so she worked in collaboration with the Mass General Down syndrome program in that role. And she worked at the Adult Down Syndrome Clinic at Ohio State University, and she also helped relaunch their multidisciplinary clinic for adults with Down syndrome. And she's brought genetic counseling services to the nationwide Children's Hospital Down Syndrome Clinic. And I do want to say, just real quick little personal story, but this past weekend I drove out to Columbus, Ohio and back with my son because he was speaking at my sister's ordination. And so my son was speaking, and so we were there for the weekend, and as we went around Columbus, every person with Down syndrome that I saw, whether it was in the community or in the church, she has a very inclusive church, or waiting on us in Bob Evans. I was thinking, I bet you know Dr. Santoro. So anyway, with that, we'd like to welcome her to Massachusetts, and we look forward to your presentation. Thank you.
Thank you so much. What a great introduction, thanks. So I'll talk a little bit about healthcare for adults with Down syndrome. So you heard a little bit of my intro. My background is that I trained in pediatrics and medical genetics, so I did a combined residency. So genetics is kind of a subspecialty of its own. It's not a part of pediatrics. So a lot of geneticists see people with genetic conditions of any age. So that's kind of how I fit in with all of this. I have no disclosures to report. I am an unpaid member of the governing board of Down Syndrome Association of Central Ohio, and I also volunteer for them until the end of my term in January. So I still have some Ohio connections. I'll quickly talk a little bit about health surveillance for adults with Down syndrome, some special considerations, and then give you lots of resources. So health surveillance for folks with Down syndrome. As most of you know, Down syndrome is due to an extra copy of chromosome 21. And with that, it has an associated list of medical conditions, comorbidities, developmental issues, and things like that. List is shown here. This is from the American Academy of Pediatrics. And they quote that the rate of autism and Down syndrome is about 1%. So some families do have that dual diagnosis. The American Academy of Pediatrics has published guidelines for the care of adults with Down syndrome up to age 21, so kind of the young adult range. And different versions of health supervision guidelines have been published by different groups since the 1980s. So these are kind of well-established recommendations for care. And they give you lots of guidance about diagnosis, counseling, screening, different things that should be done throughout the lifespan. And this table from the very last page gives you kind of a column layout of what should be done within a specific age range. Like I said, the AAP gives you guidance up to about 21 years or so, and these are the specific things that the American Academy of Pediatrics talks about for young adults. So things like looking for changes in gait, things that could go along with adrenoaxial instability that I'll talk about quickly, looking at hearing, looking for sleep apnea that we heard about a little bit before, and vision, and many other things. I highlighted in green the comment about facilitating transition, because this is a really important one that a lot of families come to our clinic to meet with our social worker and to help navigate through this process. I was going to go through kind of the details of some of these specific guidelines, but I'll just kind of skip to the summary slide. So over time, some of the guidelines for different components of Down syndrome have changed. So in the past, for adrenoaxial instability, they recommended those cervical spine x-rays for all people with Down syndrome. Now they recommend that you only get those x-rays if they have symptoms. So changes in walking, changes in using arms and legs, and things like that. So that's kind of a change that's occurred over time with the most recent guidelines. Another change is that in the past they had only recommended a sleep study if patients had symptoms of sleep apnea, and now it's recommended for all kids starting around 4 years of age. So that's another thing that's changed over time. And then screening for celiac was also recommended for all patients in the past. and now it's only recommended if you have symptoms of celiac disease, like diarrhea, constipation, unexplained weight loss, those kinds of things. Even though there are great healthcare guidelines established and published, a lot of people don't follow them. And part of it could just be knowledge, part of it could be that some of these tests are hard to do. So not sure quite why exactly, but there have been a fair number of papers that show that not all guidelines are followed. There was a paper here from the Down syndrome clinic at Mass General, and it showed that coming to the subspecialty clinic added a lot to care with new diagnoses, new referrals, and new studies being done. And then this is a study that I did in Cincinnati showing that education of pediatricians helps improve how the guidelines are followed. So it's not all doom and gloom. We can improve adherence to the guidelines, but we know that not everyone does them all the time. To give you a few references, there are some really good textbooks for adults with Down syndrome. Most of them, these are my two favorite, but most of the really good ones are through Woodbine House, so I put that website there. There is also a publication about healthcare for adults with Down syndrome. If you can read the small font, this paper is from 1999, so a bit older. And their methods looked at 38 individuals with Down syndrome. They looked at what comorbidities and other medical issues they had. And then just based on that, they suggested how to screen folks with Down syndrome. So not quite as, rigorous and evidence-based as most guideline papers are, but this is one guideline, one suggestion that we do have. Other important papers for adults with Down syndrome, there's one looking at health-related quality of life. So if you're ever wondering about kind of how to measure quality of life or anything like that, there's been one paper about that. There's another paper looking at kind of overall medical, social communication and daily living skills in adults with Down syndrome. So this shows kind of the rates of certain medical issues in adults. And it also gives kind of information about abilities and things like that, but it doesn't suggest kind of aspects of screening or care. So it doesn't really give a guideline, it just tells you what things to look out for. And then this publication looking at aging and end of life with adults, this is a review article. It mainly focuses again on kind of the rates and how often certain things are seen in Down syndrome. And these are the main things that it reviewed. So if you wanted a good paper to look at what evidence there is for those, that's another good paper. But it doesn't provide any kind of surveillance recommendations. So I think I've gotten maybe the point across that there aren't really good established guidelines for the health of adults with Down syndrome. So we did a study looking at what evidence there is to make those guidelines or how to start creating them. So this was a big multi-site, many people involved study reviewing the literature systematically. And we looked at 7 different topics, and we basically found that there wasn't a ton of evidence out there. There's not a lot of really good case control studies that are designed with really strong evidence to help someone write a guideline. So one really big important take-home point is that there needs to be more research on adults with Down syndrome in a really well-designed case control type way to be able to make guidelines in the future. So most of the time we have to rely on our clinical experience in caring for adults with Down syndrome. So one thing I always like to keep in mind is that in the Down syndrome community especially, we often think that people with Down syndrome are more alike than they are different. So if there's something that you would do routinely for any adult, you probably should think about doing that for an adult with Down syndrome, unless there's some reason not to. But most of the time we really should follow the same standard of care that any adult would receive. So of course you would do kind of your typical annual exam things like regular screenings, staying up to date on immunizations, and monitoring weight, BMI, and blood pressure. These are some specific things that I've started to routinely do over time. So these are just kind of my clinical experience combined with some of those references I mentioned. So I always make sure to ask about sleep apnea that we heard about, how important sleep is. And if it's present, then we usually refer to a sleep medicine doctor and get a sleep study. And some of the symptoms I always ask patients about, again, we heard before, but snoring, restless sleep, falling asleep in the car on drives, daytime sleepiness, anything related to sleep, I think it's really important to rule out that there's any sleep apnea, just like we talked about. I also ask about myelopathic signs, so this can go with that antoaxial instability and the need for the x-rays. So those are the symptoms I mentioned before, so changes in walking, changes in arms and legs. And if that's present, then we always start with getting a neutral x-ray of the spine. And if that's okay, then you would move on to flexion, extension, different views of the cervical spine. And then the last one we always think about is acquired valve disease. So the things you think about there are fatigue, shortness of breath, or getting short of breath when you climb stairs or exert yourself. So these are, typical things I try to ask every single patient about. On physical exam, similar things, looking for those myelopathic signs and symptoms. So I do a neurologic exam on every patient, and then looking for any signs of a valve disease, so listening to the heart and looking for any signs of that. These are the standard labs and evaluation I do, but everyone, follows some of these things differently depending on if you're looking at one of those papers I mentioned or the textbooks. Sometimes the frequency that you would do these differs depending on your source, but looking at a glucose, thyroid function, hemoglobin, celiac disease, the cervical spine if symptomatic, bone we talked about before, so bone density is important, sleep studies, and then colonoscopies and pap smears like we heard too. I typically refer folks to ophthalmology and then audiology and dental. Those are the main things I'm thinking about there, and making sure they're plugged in with a gynecologist if needed. We have a really good gynecologist that we connect with at Mass General that we refer most of our patients to, because that can be difficult for patients with Down syndrome. A few things that I try to discuss at every visit, so skin, hair, and scalp issues. Folks with Down syndrome have dry skin, sometimes thin hair, hair loss, either in sections or just overall. And so we talk about a lot of these things. Some of the common things are a good moisturizer over the counter, and if some of those kind of first line things don't work, again, we have a really good dermatologist we refer everyone to at Mass General. Along with sleep apnea, the risk for obesity is increased in Down syndrome, and those two can kind of go together. In addition, in Down syndrome, with the low tone, there's also a relative macroglossia, so the tongue is relatively larger. So there are a lot of factors in Down syndrome that make the risk for sleep apnea higher. So this is something we always talk about, but with obesity being really important, we have a dietitian in our clinic who also talks about diet, exercise, and different resources to get involved. There's the Buddy Up tennis group that's really good. It pairs a person with Down syndrome with a tennis pro, and then they work together and learn tennis together, so that's really nice. And then the Special Olympics, of course, too. Sleep apnea I've talked about a bit, so we'll just kind of skip that. But based on that new change in the AAP guidelines, I think it's important, if someone has never had a sleep study, then I typically try to encourage them to have one at least once. It is tough to be admitted and have all the leads on your head and all the wires attached and all that. So it can be difficult, but we do have someone we work with who does desensitization for that. So that's an option. And then the same thing for CPAP. Sometimes if there is sleep apnea and they need CPAP, there's someone who can help us with the CPAP desensitization. So it's a bit of a process sometimes, but we can work through this because sleep really is important. Social issues I mentioned. Sexuality and dating. This is something also really important that I always try to talk about. And again, we have a social worker, a gynecologist, and lots of people on the team who address these issues. And then this was a newer paper that came out regarding pharmacotherapy in Down syndrome. It's a really nice review with Dr. Palumbo here, and she kind of goes with her co-authors. She goes through the different comorbidities with Down syndrome and the different management recommendations that she typically does. So I think it's a really nice paper if you're ever looking for a good resource. All right, and last, just a few additional unique considerations for Down syndrome. So most of you may know this, but Alzheimer's disease is more common in the Down syndrome population. And part of that is that well, let me skip to the next slide. So there's a gene on chromosome 21 called the APP gene, and because folks with Down syndrome have 3 copies of 21, they have 3 copies of this APP gene, and by having this 3rd copy, it's like having an extra dose of the gene, and that leads to amyloid creation and then earlier onset of some of the features of Alzheimer's disease. So the number most people say is 40% by 40. So that 40% of people with Down syndrome would have Alzheimer's disease by 40. And then over time it does increase. So it's a really important thing that we're always thinking about when we see folks with Down syndrome. Regression is another unique thing in Down syndrome. So unlike autism, that's usually at a younger age, and Alzheimer's disease, that's usually at a later age, there's this additional entity, usually at the late teens and early adulthood, where folks with Down syndrome can lose many of their skills, motor skills, self-care skills, sometimes speech, and it's pretty noticeable, and it usually occurs over months, a few months up to 6 months or so. So this is something that's relatively new and is getting more attention and awareness over the last 10 years or so. And so we're still trying to learn a lot more about this entity and what it means, how to diagnose it, what to call it, all of that. But this is something in our clinic that we're very focused on and really would like to learn more about. So if you happen to know of anyone with this kind of presentation, I'd really like to talk to you and learn more. For growth in Down syndrome, these are the 2 growth curves. So on the right is the curves for height and weight from the CDC for children, and then on the left is the height and weight for Down syndrome. And the thing I think you can really see, my pointer will show, for the weight, there's this really large range of kind of what's normal from the 5th to 95th percentile. Whereas on the typical curve, it's much more narrow. You can just see this part so much wider. So the older Down syndrome growth curves kind of allowed our patients to be in the normal range, but they truly were obese. So if you look at BMI, you can see the same kind of thing. So this is the BMIs over 30 on the Down syndrome curves. These are the older ones for boys and then for girls. And you can see there's so many who had the BMI over 30 but are still kind of within on the curve, basically. So new curves were created a couple years ago, and we're now using these. We also still use the BMI curves from the CDC and the WHO and kind of look at growth overall. Iron deficiency, we heard mentioned too, so this is really important in Down syndrome as well. There have been a few studies that show that iron deficiency is more common in Down syndrome, even without iron deficiency anemia. So even before you're anemic, you can have iron deficiency. So this is a new thing that we've started screening for routinely in all of our patients in the clinic to check their iron levels, because if you can supplement with iron and improve it, then it can improve mood, behavior, and many of those things. So kind of in summary, for care of adults with Down syndrome, There are guidelines from the American Academy of Pediatrics that go into early adulthood. There aren't any really evidence-based standardized guidelines for adults with Down syndrome after that age. So we put together different references and our clinical experience to guide our care. And the most important thing, I think, is that each person with Down syndrome is still an individual. So beyond just thinking of what's related to Down syndrome, you have to think about what's important for that patient if they have things beyond Down syndrome itself. So in the last 2 minutes, I thought I'd just show you a few different resources. So there are lots of great Down syndrome organizations, local and national. So the Massachusetts Down Syndrome Congress is the national or the local group, and then there's the NDSS and bigger national groups. There's one specific for mosaic Down syndrome, and there's the Down syndrome medical interest group if you know any medical providers who might be interested in joining. We have therapists, nutritionists, physicians, nurses, lots of different people in the medical group, and we think it's really helpful to have lots of different input. We meet once a year usually at a national conference combined with the NDSS, and it's a really nice group and a way to, I don't know, connect with other people who are studying the same thing, and it's part of how I collaborated with MGH when I was in Ohio. So,
Excuse me, Dr. Santoro, could you
Yeah.
explain what mosaic Down syndrome is to people?
Sure.
Not everybody might know.
yeah, sure. So mosaic Down syndrome is where some of the cells have the extra copy of chromosome 21 and some don't. And there have been a lot of studies looking at like the percent of mosaicism over time, and that can change over time. And there have been a lot of studies comparing those with mosaic Down syndrome to the rest of kind of the typical trisomy 21 Down syndrome. And we used to think many years ago that those with mosaic would be much less affected, I guess, and have fewer symptoms, fewer medical issues and that, but it doesn't really pan out to be the case. So we do the same medical care for folks with mosaic Down syndrome just to make sure we're covering anything that they could be more likely to have.
Thank you.
Yeah. And then just to let you know a little bit about our program. So this is our large team. I like quality improvement, so that's my role, but our good director, Dr. Brian Scottco, he really is the national world expert about Down syndrome. We have other physicians, we have a lot of support staff, our psychiatrist, Dr. Palumbo, psychologists, and then, you know, just lots of therapists and a really big team that it takes everyone to make it all work.
Can I just interject? I know I'm being rude, but that
No,
little
it's fine.
guy on the second row,
Oh,
I
yeah.
met him in a play group when he was 1. He's
Yeah.
just so, it's just so delightful for me to see that Ben's
Yeah.
on your staff. I love
Yeah.
that.
Yeah. So Ben is great. He really, when I started, he really was like such a joy to me. I would get lost in the clinic almost every day, and he would help me, you know, to get to the right room and get where I needed to be. So he really helps make the clinic flow, and he meets with each patient and each family, and he has social stories and different handouts and things that he does. So for example, he has sleep apnea and wears CPAP. So if someone is thinking about having a sleep study or thinking about wearing CPAP, he can talk to them about that. So he really is an integral part of the clinic. Thanks for mentioning. Yeah. And then we see patients prenatally if they have been given a diagnosis or are even suspected to have a pregnancy with Down syndrome. We have an infant and toddler clinic. We have a separate child clinic, and this is just showing you all the people that are part of the clinic. The top section, most of the time, patients would see all of these people on the same day. So it's a comprehensive, well-oiled machine. And then we have an adolescent and young adult clinic, and then an adult clinic. We also do research. So we have a separate research team. And then this is our webpage. If you have any questions, want to be referred, want to learn more. And I just wanted to mention, if you click on You can't see it right here, but if you go to the website and look out patient handouts, there is a wealth of knowledge and handouts about so many topics that is really, really helpful. Anything from dry skin to getting a sleep study. I mean, anything you can think of, it's on the website, so it's really great. And I'm happy to answer any questions. I have clinic later, so I'll try to answer them now if that's okay.
That's fine, yeah. I was just going to get up to say
Thank
that.
you so much for your time.
Can I just ask you to touch on one other base?
Sure.
So we're so grateful and fortunate to have the Lurie Center in our area and to have these Down syndrome programs as well in the area. And I believe I once heard the statistic that there are only 37 such Down syndrome programs in the country, which as you do the math, of course, there's not even one in every state. And I believe Massachusetts has 2. Am I correct?
Yep.
So, but the other thing that they do, which is wonderful, is Dr. Scotko told me that they've developed an online questionnaire. If you live in a state or an area that does not have a Down syndrome program, you can fill out this questionnaire with your information about your child, and it produces this output at the end that says, based on what you've told us about your child, we think these are some questions you should ask your doctor. And so I just think that's a very valuable tool for folks who aren't fortunate enough to live near centers like this. So I don't mean, maybe you were going to say that anyway, but I just love that. But anyway, if people do have questions for Dr. Santoro, go ahead.
One quick question.
Sure.
I have somebody who has A1 care and has to go through the Boston clinic, but he's out of Boston Medical, and we are struggling to get a sleep study done. Is there any way that, how can we do it through, because he's got Down syndrome, he's got reflux too, is there any way that possibly we could try and get it somehow a relapse and whatever, possibly to do that?
Yeah.
How do we go about doing that?
I don't know. I'll tell you the answer. I don't know the specifics of the insurance coverage in that, but we don't have any trouble getting the sleep study done for the patients we see in our clinic. So maybe if you email me, if you want to email me, I can help connect you with kind of our sleep study team and see if there's a way to get that done.
Yeah, we're also doing a referral to Dr. Moran because he's also coming down with dementia too, so
Yeah.
we've got a lot of issues going on.
Yeah.
All right, thank you.
Yeah, and I mean, correct me if I'm wrong, but I don't know that the Boston program sees into adulthood. I thought it was more focused on the pediatric age.
Children's.
Yeah, at Boston Children's.
They're in Boston Medical.
Oh,
It's different.
It's different. No, he goes into Boston Medical, so
Okay.
Boston Medical Hospital, that's totally.
but I don't think they have like a comprehensive program for adults like this at Boston Medical, right? Yeah. So I guess what I'm wondering is maybe they would even want to come to the clinic for like a comprehensive evaluation. So yeah, feel free to email me and we can see. Yeah. Yeah.
I actually don't have a question, but to answer your question, I just recently, I work with a young woman, she's a young woman, she's my age, so she's very young, with Down syndrome, and we were just seeing her clinic with Dr. O and the team, and it was remarkable. And what we've been able to accomplish in a very short period of time. But so everything you spoke about, the blood work to the audiology and ophthalmology exams, we've got those all scheduled. I just got a call from the sleep study people to get that scheduled. So it really is a remarkable program, and I'm just so grateful because she's now exhibiting signs of dementia. And so we're going to be setting up neuropsych testing and really, and it's been an amazing resource for me as a nurse, and so that I can relate it to the family as well. So it's just been remarkable. So thank you for being available.
That's great to hear.
But I can help you to make the connections
Thank you.
with who you need to contact up there. So
Yeah, great, thanks.
thank you.
I just wanted to make a comment too. Thank you so much, Dr. Santoro and Dr. Neumeyer. Mara Sullivan, I'm the Director of Operation House Calls, and we are reaching out over 600 medical students and health professionals every year. and we are teaching them much of what you guys have just presented, mostly focusing on looking beyond behaviors and avoiding that diagnostic overshadowing. But we really look to you and Dr. Scocco and the Lurie Center for all that new information that you have and all the idiosyncrasies that we need to get out there of each individual. So thank you so much for doing this.
Yeah, you're welcome. It's crazy. I mean, the little things do change over time, even from year to year. It's great. There's more evidence coming out, and there are new studies that really change some of what the guidelines say and what we do. So yeah, I think it's really great to have that connection. Yeah.
Any other questions for Dr. Santoro?
Thank you.
Thank you. Oh, there's my family. So as we switch to the next presenter, I'll just say, and those of you who are parents in the crowd, I know you know this from your own experiences, but as Brian was growing up, we worked so hard with our medical community. And the list that she had up here, we hit them all. We had so many of those issues, so many hospitalizations, ear tubes, dental, knee surgeries, sleep apnea, tonsillectomy, adenoidectomy, periorbital cellulitis 7 times that only responded to intravenous, it was just such an assembly of doctors, and we just wanted to keep them forever. And I remember at one of my daughter's soccer games, a doctor from MGH said, okay, now Brian's 20, you need to transition to adult services. And I thought, no, you don't understand. All these people know everything that we've been through, and we can't transition. And yet it was so wonderful, because this team, when we went, they really do have the checklist of adult issues that we weren't even looking for. They weren't on our radar screen. So it really, if any of you have not made that transition, if you just love your pediatrician so much in your pediatric care, you're reluctant to let go, you really need to take that next step and get to these adult programs, because they are so wonderful. So with that, I'm going to introduce our final speaker, and this is Dr. Julie Moran. It's funny, we have so many Julies here today. And many of you know her, because I know a number of you are associated with DDS. And Dr. Moran is a clinical instructor at Harvard Medical School. She's a consultant physician, and she works at the Department of Developmental Services as their geriatrics physician. And so, of course, that means she considers all the wonderful, such a wide range of needs of the elderly, including chronic diseases, nutritional problems, skin ailments, cognitive loss, memory impairment, adverse effective medications, immobility, and balance issues. So she's sort of going to just give you a broad perspective. So thank you.
Sure. Thanks, Julie. Thanks for inviting me to be part of this presentation. I'm really excited to be part of this panel. So yes, I'm Julie Moran. My specialty is adults with intellectual disability. I'm trained as a geriatrician and an internist. I do consult for the Department of Developmental Services 2 days a week, and then also work at Tewksbury Hospital, which is a state public health hospital that has specialty care unit for adults with intellectual disability who need short to longer term stays to work on specific problems. That runs the entire gamut. But my role is really 100% immersed in the field of adults with intellectual disabilities. I'm happy to be the third speaker for today, because I think in follow-up I'm not going to be repeating some of the things that were already said, but would echo a lot of the things that were already said, nodding my head a lot to everything that the 2 doctors ahead of me said. But I was thinking, with the time constraint that we have, not that for 20 minutes, I thought there were 2 big themes that I'd like to introduce today, and kind of give you something to think about and something to hold on to that I think are really become kind of 2 big cornerstones of the work that I do, especially since I see adults who are growing older. And so the first thing I really wanted to introduce is this concept of change. So change is really kind of when I think about, maybe I'll skip ahead to this next slide, because when I'm a geriatrician, so that if I was going to sit next to you on an airplane and explain in 1 minute what I do, I would say I'm a doctor of older patients, that would be kind of the explanation of it. But the more I live in this specialty, and the more I think about, well, what exactly am I trained to do and what's my specialty? I really think that, so some of the things that I used to grapple with, like I'm a doctor of older patients, And then people would sort of nervously say, like, well, when does that start? what do you mean by old? You know, and then we'd say, like, oh, I don't know, when you're Medicare eligible, or, but really over time, even when I was doing general geriatrics, I would say to myself, there's really nothing about your chronological age or your date of birth that means you need a geriatrician. There's somebody who's 74 right now who's doing 18 holes of golf today who doesn't need a geriatrician, but there's somebody who's maybe 54 years old who really has a lot of medical complexity, who could really use somebody who kind of throws their heads around the entire functional status and what's going on with their medications and you know, looking ahead to the future. So I think medically complex patients kind of summarizes some of it, or this concept of frailty that happens as we grow older, or maybe some complex psychosocial issues. But the main thing I thought about is that aging at its most elemental is really all about change. And so that's the concept I think for within 20 minutes, I want you guys to kind of let that sort of permeate for today. And I think what's nice about focusing on that rather than, for me, specific and we can certainly in questions, I'm happy to answer medical specific questions. But I think there's a lot of empowerment in thinking about concepts of change because it allows you to think a little bit about noticing things. Everybody in this audience who has somebody that they care about is the expert on that individual. We on the medical side, with our guidelines and our standards of care, we are never going to be more expert about your individual than you are. And so I think there's a lot of empowerment in being able to have a framework of looking at how you're noticing things are changing so that you can help us do the best job for you. Because I agree, we're detectives, we're often trying to problem solve, and you help us do our job better by helping us get halfway there with understanding what's going on and what's looking different. So when I see people in consultation, I think about this as regardless of what people come to see me for, which we call their chief complaint, I'm concerned about memory, I'm concerned about walking differently. I kind of scrub all that out in my mind and I just look at it as change. Something looks different, and we're trying to figure out what that is. And I think even starting from a framework of noticing change and trying to understand and appreciate what might be changing helps not bias me in any direction, that I'm just listening for your memory symptoms or something, but really saying I'm keeping my eyes open to really listening to what's looking different in this individual. So the geriatric assessment, change is really the common theme of any geriatric assessment, whether you're specifically brought to see me because you're worried about a change in mood or function or behavior or memory, which is often one of the biggest things that brings people around the table. We're really looking for what is it exactly that's changing, what's looking different, what could be the key contributing factors to that. So I think a lot of what Dr. Neumeyer and Dr. Santoro were talking about is all the things that kind of are running in the background as you're assessing somebody. Which items are we identifying that are actually modifiable? What can we do something about? What are some of these targets that we're identifying that we can actually start an action plan around? And which factors are potentially improvable or treatable? So when assessing change over time, whenever I see somebody, for those of you who have come to an assessment with me, I usually say the same sort of spiel where I say, if I'm seeing you for the first time, but the thing that brought you to see me is that something's looking different. I've missed out on all 55 years of your life, and I need to understand if we're already at point B, you're telling me something looks different, I must go back and understand what point A was for you, because there's only some way that I'm going to be able to fill in this black box here, is to understand how we got from point A to point B, and in what ways does point A look different from point B? What are the different things that have started to slide, and what things have maybe stayed the same? And you really cannot just unload that in kind of a free-form question. It really needs to be unpacked in a systematic way so you make sure you don't miss anything. So I'd say, and this is Jim, who's a patient that I met early in my training, and his mother, his dynamo mother, who was like a real pioneer back in the day and kind of kicked down doors and got stuff going for him, and kind of rejected all the advice she was given when she gave birth to him. This I think is a great timeline for me to show, because I think for me, and I think for a lot of medical trainees and people going into the healthcare field, this is kind of where we start to learn about intellectual disability, is in childhood or genetics or early childhood development. But the rest of the story is often still something that's kind of left as like a cliffhanger that you actually will grow into a 55-year-old man perhaps after your diagnosis with Down syndrome. So when I'm thinking about seeing somebody, when I already see somebody like Jim, he might be right here at point B. And I need to kind of roll the story back to point A to understand how we got from there to there. And that's all done through history. So a general approach to assessing change over time is to really establish a historic baseline. So this comes up for me if I'm meeting somebody for the first time. I need you or whoever is there to be the best person to kind of help me understand the story about, tell me about what we were able to do at our very best. And these are the components that I always do and ask specifically about, because it kind of covers all the major domains for me that I need to understand. And that basically counts for basic functioning, which is really about care of your own body. You know, when you got up in the morning, were you always somebody who was able to just go take a shower, use the bathroom, come down for breakfast, get off to the van, whatever it was? Or have you always needed some level of assistance about that? And we'll thin slice that. Tell me about showering, toileting, dressing, grooming, etc. Skills really encompass things like, to start with, tell me about academic achievements, reading, writing, math, money skills, employment history if there ever was one, what we would do for if we went off to day programming, etc. What were our abilities around the house? Were we somebody who would kind of independently do meal planning and help with kitchen preparation and set the table? Give me a little bit more detail about what we were typically capable of about with household chores. Hobbies, sports, other abilities that we would do on a rainy Saturday. How would we spend our time? What was fun for you? Did you travel? Did you use the bus independently, etc.? Memory skills really have to do with what the individual was always capable of in terms of recognizing daily routines, being aware of day and date, learning names of familiar people, being able to recognize familiar faces. So even for people who kind of shrug when they start to talk about somebody with asking about baseline memory skills, even if somebody never had expressive verbal speech, you can always understand, you can always get some description of what their memory was for how they recognized patterns of the day, whether or not they were able to navigate around familiar places, recognize familiar faces, etc. Baseline behaviors are really important to talk about too, because oftentimes problematic behaviors or the emergence of a problematic behavior is what people, gets people urgently in to get some help with. So it's really helpful to understand whether or not certain behaviors have always been there and maybe the dial's been turned way up on them over the past couple of years, or if it's a totally new behavior. But for baseline kind of understanding, what would typical behaviors be, what things they struggled with, even things that are really not problematic behaviors but more quirks, about self-dialogue or self-talk, just understanding kind of the lay of the land about what was typical. Language abilities has more to do with expressive speech and our ability to understand verbal language, whether or not we were able to ask for what we need and want, or if there are other ways that we used to communicate. What our typical personality was like. So this would be, if you were social or gregarious, kind of the mayor of the town, or if you've always tended to kind of stick to yourself. And mood, again, pretty self-explanatory, but just understanding, like, even just stretching out, 20 years worth of history. Was it always this rocky course, or were you always a pretty easygoing person, pretty happy-go-lucky, easygoing, content? So this, for me, is what I would consider point A. So I like to hear things in like a storytelling narrative format. For me, that helps sort of paint a more specific picture of an individual. And as we're having this conversation, it segues really nicely over to that point B. So when we think about evaluating change in adults with intellectual disability, history is really the king, yes, or queen. Yesterday I had clinic and I was saying this same thing that I had told to other people because they were worried. It was an individual who had come to see me because they were worried about mood and behavior and memory. And she sort of played possum with me and was just like done with me by the time it got to memory testing, where we do some interactive things. And I said to them, like, if I had to do my work and still be on, like, if I was on a desert island and still had to do my work, I would always choose history taking as the one ability I would take with me, rather than any of my toolbox about testing or anything interactive, because history is what gets you really kind of 90% there in terms of understanding what might be going on with somebody. So again, the challenges to history taking in my world is that the historian is really the key to the history giving. So we want to make sure that an individual is being brought to the physician with a good historian, somebody who knows the individual well. In my work, and I'm sure for Dr. Santoro and Dr. Neumeyer, those visits are usually pretty highly anticipated and well planned for, so oftentimes we do see people come with, you know, a nice complement of good historians and people who know the individual well. But it does still happen. It happened just a few weeks ago that somebody came with like a relief staff who was told that morning that they had to drive to Worcester to come and see, you know, so sometimes it does happen where you're just really struggling, but it doesn't mean that all hope is lost. It just means that I often get on the phone after the visit and get my history, because it's so key. You really can't do without it. So once point A is established, I always go over the same domains that we just talked about. So for me, the way my mind works, what's helpful is I have this picture of somebody who had all of these skills that they were just describing to me, and then we retrace over those same steps. Okay, tell me what day-to-day function looks like now. How much help do they need getting into the shower? Do they need new help getting into the toilet? What other things are they noticing at date program? So that already I'm starting to create some sort of mental lines between point A and point B column to say, okay, that sounds pretty stable, but oh my goodness, you're really describing a lot of things are shifting in mood or behavior, etc. And then you just compare and contrast the differences. So when I think about aging and this concept of aging, kind of getting back to this point originally about what is geriatrics and what are the main points about aging, this is just a slide that I wanted to pull up just to illustrate how the aging process is sometimes schematically put out there as like that it's this growth, it's a growth curve that's very rapid in early childhood development, and then we sort of hit a plateau, and then there's kind of this senescent period towards end of life. And usually my lived experience of change as a function of time is that usually by the time I start to see people, this is kind of more what aging looks like, right? We're sort of all over the map. Highs and lows, there was that time that we had that, you know, acute gallbladder attack and we really plummeted, and then we rallied back, and 5 months later we were back to program, etc. So usually, where's my thing? So when I'm assessing change, I usually tell people, if I'm meeting you for the first time here, like you've called for an appointment because you're like, oh my goodness, we're like really on a rocky course, I really need to know what you were like there. So that's point A and point B again, in kind of that schematic period. So just as another example of how this would be kind of drawn out, just as an example, for instance, if I took a history from somebody who was previously independent in all self-care, and now I'm hearing that there's assistance needed with bathing and dressing, or somebody who used to work competitively and could read and write, and now they're seeing those work skills are starting to slide, or somebody who had fantastic memory for names, birthdays, phone numbers, and now is forgetful of their daily schedule. Occasional acting out for behavior, but now we're aggressive at times of self-care, and we're really attempting to hit staff when we're interacted with, language skills, etc. So that, to me, that kind of schematic really gets me caught up with where we were in life and helps me bring me straight into present day so I can understand where things are starting to look different. And already it's starting to bring up some questions in myself too, which then leads to other things, like if sometimes this kind of history taking also leads us to maybe looking at the calendar. Boy, you're talking a lot about ever since summer of 2017, such and such happened, and then we're able to kind of drill down even further. Well, what happened around then? Oh, well, that's when mom got sick, or that's when the group home manager quit, or some other type of thing that starts to help drill deeper and deeper with that detective work. One thing that I can never resist teaching without, and this concept is this picture. I don't know, for those of you who've already heard me teach with this picture, but I always say that that point A in picture format could be best illustrated perhaps with this picture of Jim, my friend who I learned about and met earlier in my training. So this is Jim on a night out at his day hab program, and it was a award ceremony to recognize him as Client of the Year. And the point that I always want to say about this picture is the person who nominated Jim for this award was Jim himself. He looks like $1 million. He's out at night. He looks fantastic. He wrote, and his beautiful mother, showed me this letter of how he, outlined all of his criteria for how he is clearly the only person who deserves this award. And here he is winning that award at the end of the night. And so, see how much this picture and that story already jumps you straight ahead to understanding, okay, I think I understand this guy. So Jim is also that individual who I showed you in that chronology of 4 pictures. When I met him, he had mid-stage dementia. This picture and point B, when I met him, gives you a much rich picture of what that kind of understanding of change really looks like. What this idea about change, so let me share this before we move on to the next concept. The point about this, and what I think is so important about kind of highlighting this idea of change, is that so much of what I described to you about this point A and point B is stuff that you guys can do as caregivers and as care providers. And so, especially when we're thinking, like, if right now we're just in, if there's any individual that you're talking about that you're caring for, and as we're growing older or we're just into adulthood, it's really important even just proactively to think about these kind of point A factors that we can be creating some sort of a time capsule of. So whether it's a short little video clip of an individual riding their bike or baking brownies with their grandmother, or a little clip of what their handwriting looked like, that kind of time capsule of information that really helps enhance the understanding of anybody's understanding of where we started from in life. And then for anybody that you're concerned about for growing older, already starting to do this mental exercise in your head about what is it that's looking different, because it already starts to point you in a different direction. I think for probably, I don't want to speak for all of us specifically, but I know for me, I do have the benefit of more time with an individual, and I think that's probably owed or allowed to some people who choose specialties and have a little bit more support around that. Practically speaking, for most individuals, if they're trying to get in the door with their primary care doctor, they might have 10 or 15 minutes. This is not going to be what's unpacked in a 10 to 15 minute visit. But you, on your own, or anyone else who cares for that individual, can do this sort of exercise and really think about it and think about what's looking different. That also can help you kind of nudge certain things in a certain direction. Like, no, what I'm telling you is that since April of this year, he has consistently been walking in XYZ fashion, which he has never walked like before. You know, thinking back about what it is specifically, rather than just saying, I'm worried about him, he's looking different, you know? That's how you end up kind of either getting a premature diagnosis of something, or having something, you know, just regarded as maybe the progression of their disability, which is kind of a strange concept in general. But oftentimes things are really not kind of drilled down to the level that we would hope them to be to really get us to something, a meaningful endpoint. But that's a lot of things that's hopefully heard on your end as sort of empowering, that you can actually do a lot of that thinking and kind of problem solving and half of that detective work too, to help us kind of find our way to it.
Dr. Moran, we're down to just about 3 or 4 minutes, so okay. I know you have a whole new concept, so.
All right, it's quick.
Okay.
But it's also something like, my goal would be that you like drive home thinking about this, so that this is like concepts in your head that you can kind of think about. So the thing that's sort of a handshake off of this idea about looking at change is that it's not really, it's all looking for something that's impactful, so we can understand what the things are that are actually driving change. And then ultimately for myself, it's all about how do we set proper expectations, so that this is not just something that, you know, we've done our best to kind of look at different coexisting conditions, but really being able to do a now what at the end of a whole discussion, right? So this comes up a lot for people who I'm seeing for memory, that it's not so much like, oh, bravo, you came up with the right academic diagnosis of a memory disorder, but really it's almost like an Etch-a-Sketch. You just like shake the slate clean, that now that you've done all the diagnostic work, now there's a whole new discussion about, well, what do we do now? It's actually extremely important, but it's often overlooked part of the discussion. It's usually all about diagnosis or ruling out other things. But then, you know, off goes the person home with a diagnosis that they are going to be living with every day. We want to make sure that the diagnosis is accurate and that we're also providing a lot of resources and education around what to do about it. So it really involves synthesizing all information, and it helps reality test future plans and brings additional clarity to the root cause of underlying changes. I'm going to change that. So it really empowers individuals and caregivers and involved team members to prepare properly for the future. And because it really, really matters to the people who are sitting in front of me. For example, I had an individual who I saw who actually did meet criteria for a dementia diagnosis. She was living at home with a shared living provider who had been her caregiver for 20 years, but she herself was a younger woman when she became a caregiver. So she was a caregiver for a woman who developed dementia, but was also the mother of 4 children under the age of 12. So I'm not just giving a diagnosis, I'm letting her know what's about to unfold in her household over the next 5 or so years. And so that now what, or that expectation setting is hugely important in so many different levels. Or an 80-year-old mother who's been the primary caregiver for her 56-year-old son for her entire life and plans on keeping him home forever. And how do we kind of take that to the next step and sort of think about what things are sustainable and what else, how can we kind of reality test that as time goes on. So for me, it's all part of the same continuum, that we are evaluating change, we gather information to make a decision, we make a plan, we make a strategy, we assess the impact, and then the wrap-up of all of that is, what have we learned from all of this? What are the things that we can expect for this? These are the things that we've identified as modifiable or improvable, and if there's nothing that we feel like there's some direct impact on, how do we help people feel prepared for the future, and how do we create a resource team and network around them to make them feel supported and make them feel clear and satisfied that they understand that diagnosis, they feel satisfied with the accuracy of that diagnosis, and they know they've done everything they can to look for other root causes. I'll show you a few resources. This is the Aging and Down Syndrome Guidebook that I helped author in 2013 through the National Down Syndrome Society. Coming soon is book 2, which is already online, but should be published in print shortly. And this is called Alzheimer's Disease and Down Syndrome, a practical guidebook for caregivers. It's actually meant to be something that's a manual just about the topic itself, so it's really not just for anybody who has a diagnosis, for anybody who's interested in the facts around this risk. And the other is that for those of you who are not aware, there's publicly accessible whole complement of webinars that are available that the Department of Developmental Services helped put together. For those that are related to aging, you will see my face again for a lot of them, but it's under this tab at the Eunice Kennedy Shriver Center, and looking under this tab, Aging with Intellectual Disability Trainings, and then there's a whole complement of webinars that you can click on there. So I'm happy to take questions afterwards as part of the panel, but thanks so much for your attention today. I appreciate it.
Great. So Dr. Santoro does have clinic hours, and she's new to metropolitan Boston and Boston traffic. So if you have questions for Dr. Santoro, I'd want those to be up front, but then we have questions for all 3 doctors. We have time. So does anybody have anything they'd like to ask? Thank you so much. I'm just so thrilled. Your presentations were all very helpful and very different. Great information, very different. Thank you so much. Questions? Yes.
I know a lot of the presentation was very specific to autism and Down syndrome, but my daughter has developmental disabilities, and often that's very complex of where her needs are. And I'm wondering if what a lot was presented, if that how that gets utilized with doctors in trying to support her as an adult with disabilities in a clinical setting.
And how old is she?
39.
Okay, doctors?
You know what, let's turn our chairs around.
Sure. And you heard her question?
It's okay.
Bye-bye. Thank you so much.
Thank you so much.
So nice to meet you all. Come up here. Can you state the question again?
Sure. My question is, often in a clinical setting, when you have an individual with developmental disabilities, it's very hard to find a PCP or an internist who has actually dealt with individuals with disabilities, and not necessarily autism or Down syndrome specifically. And I'm wondering if some of the issues that you raised are applicable to those with multiple disabilities, and how you go about, either educating the clinician on how to deal with this, or find a clinician who will deal with an adult with disabilities.
So the easy question is, yes, everything applies that we talked about to an individual with other disabilities. And then to find somebody, generally speaking, I find that people who've trained in family practice have learned how to care for children who are nonverbal. And so I find in general, not specifically, but in general, they're much better at taking care of people who have intellectual disabilities or autism or whatever. But they generally do better because when you care for children, you're used to caring for someone who can't express themselves verbally. And so they're used to asking the parents or the caretaker, and they're more understanding of someone who's fearful. So maybe you want
It's
to add.
interesting I've actually said that same thing, and I'm not family medicine trained myself, but I think at least if you were just looking in general, I would agree with Dr. Neumeyer that sometimes I think for adult providers, the concern really has to do with the very basic logistics of like, I don't know how to take a history from anybody but the patient, him or herself, and trying to understand this idea about like collateral informants of, let me talk to mom, let me talk to her, one-on-one support provider, that kind of stuff. So there is some, it's not across the board, but yes, for people who are at least more versed in that kind of lifespan concept of knowing how to work around getting a history out of a 3-year-old, might be able to be a little more light on their feet with understanding how to take history from people who aren't able to communicate as well.
But most of the programs actually do not have a family care doctor. What they have is somebody who takes care of you till you're 21 or 25,
yes.
and then they push you into adult care.
Yeah.
And those individuals are looking at you going, well, I've never dealt with this before, and you search and search and search, and it's very limited.
Yeah, it is.
Right. I
We
agree.
have a hard time. I mean, we keep lists of people. And so I give talks to internists and go, please just take one patient.
Mm-hmm.
And these are the tricks for you to know about caring for one patient. And then, come back and I'll help you if you need help or whatever. But and I think actually, is she back here still, Maura?
Laura, I think she left.
No, she's
Okay,
left, yeah.
so, and Maura's working very hard also to train doctors. Med-Peds is another.
Mm-hmm.
They're doctors who have dual certification in medicine and pediatrics.
Right.
And then you just ask in the group, sometimes it's the nurse practitioner in the group who, I don't know, had a sibling with Down syndrome or something. There's often someone.
Right. And part of it too, I think I'm a real devotee to that approach that I just explained about doing some thinking yourself too, because then that also helps at least highlight certain more specific concerns. Like, I've noticed XYZ is different ever since we started this medication, or ever since, she's been kind of clutching her belly ever since we changed this or that. So, of course, I'm sure you said your daughter?
Yeah.
Yeah. You're used to that advocacy role and kind of pushing. I'm sure this is not new to you. But just, I think for some people, it's, kind of emphasizing that common things are still common, that somebody still, despite like anything about their unfamiliarity around taking care of an adult with intellectual disability, it's like everybody still gets constipated or sleep deprived or has pain. So it's not that like, oh my goodness, I couldn't even, trying to help at least sort of push towards thinking about at least some common scenarios that don't always necessarily need to be governed by a distinct awareness of what specific genetic condition it might be, that we're still like living in a human body that has very common predispositions to certain things that are uncomfortable or make us look different.
Can I just jump in here for a second? We have a provider in the back who has a very specific resource to recommend to you.
Disability.info.org, and you can
yeah.
actually plug in, what you're looking for, programs, doctors, dentists, consultants, and you can actually select the town, how many miles away, and they'll actually give you folks, and clinicians that are in your area looking for that specialty.
What's that called again?
It's disabilityinfo.org.
Thank you.
You could also go mass.gov website and actually go to either DBS or you can find different links.
Are you moderating?
Hi,
Yes, Evelyn?
I have a question, or I'd love to have you talk a little bit more about history, historians, because as a parent, I feel I know the history, but as a place where my son is not living at home, I want the staff to, and they do go, but how, it took me a long time to learn that, actually.
Yeah.
And because if I'm asking, if they hear from the, if staff hears it from the doctor, there's a certain strength in it, I think. That, But I do know what it was like when he's over 50 now. I know what it's like at 4 and 14 and 34.
Right.
And so just, I don't have a question so much as before you even mention that, and how do we get that message out, and is there a best practices way? Anything you want to say?
Now, are you speaking of like when it's time for a medical encounter and an individual is accompanied by a staff member?
Yeah.
Okay.
I mean, I'm actually been lucky enough to mostly make it annual visits.
Yes.
And the first time I was not invited to an annual visit, I was shocked. But it was not by the staff that is here listening carefully with me long before that. But I was shocked. But then I thought, hey, this really is working. But it's just
So I like when parents call in, even if they can't be at the meeting, because as you said, sometimes the person who's bringing the patient in is just helping out because somebody else suddenly couldn't come to the visit and they don't have much history. They might have a little piece of paper on which they've written 2 things, which the group home leader told them to ask about, and they've got the med list printed out, and beyond that, we don't really know what's going on. So I'm always, every physician's office has a speakerphone, and it's a great way to be there, even if if you can't physically be there. So ask the group home to help coordinate that.
Yeah. Well, can I just add one thing? Sorry, before I do also want to say though that oftentimes the group home staff are just put in a tough position because I think there is a lack of understanding, or at least what I hear amongst a lot of providers about understanding exactly what your role is, and how you really are a very appropriate spokesperson for an individual who might not be able to give as much narrative history themselves, and so. That is a challenge that I don't have an answer for, but at least want to just acknowledge. And do think that sometimes it is different if it's mom sitting there, even if mom right now lives in Florida and actually doesn't spend that much time, and it's really the group home manager who's the best spokesperson. But maybe for some providers, it's kind of easier to get it makes more logical sense maybe to hear it from mom. I am a big fan of making sure that we're involving as many informants as possible. It doesn't make the most sense to try and get that all done within the allotted time of an office visit, to have everybody speak, so some people would not really be useful, a good use of their time, but in preparation for a visit too, because most sort of organic conditions are portable. Like if you feel unwell, it goes with you to day program, and it goes with you onto 3rd shift, and it goes with you in the morning. But if it's environment specific, then it's really important to hear that like the day program person says like you're an angel, and then it's only when you get home and you're around that other housemate that like all of these behaviors come home, right? So I think that kind of also going the rounds with understanding that history is really important too.
Christine, can I just jump in here before you ask your question? Sure. I'm going to put Carrie on the spot. Carrie, could you tell them about the memo that everybody should have written in their home that accompanies their child, the adult child, with all the little pieces of information about everything?
Oh, okay,
Oh, I'm sorry, this is Carrie Mahoney. She's from the ARC of Massachusetts, and she wears many, many hats.
yeah, I think you're talking about the letter of intent?
Yes.
Which is a wonderful document for caregivers to complete. It basically is taking everything that's in your brains
about your loved ones, and it's putting it down on paper. There's a lot of different formats. If you just Google letter of intent, you'll be brought to several different ones, and it's a wonderful document. You can do it yearly, maybe on a birthday or a celebration, and it's a good piece to have in your estate plan. It's not a legal document, but it's filled with pertinent information.
And it helps to tell the story and the history. And when Dr. Santoro was here, she talked about cervical instability in people with Down syndrome. And we learned when my son was 1 year old that one of the part of his spine and his neck is malformed, misshapen. And so on every document that I've written for 27 years, it says, Brian has a misshapen part of his neck. He cannot do headstands. He cannot wrestle. He cannot play on jungle gym equipment. I've written that statement so many times. So it's those statements that you need to have written down and have in a document that you can hand to somebody at a group home or whatnot so that they know. Good, Christine, your question now.
Thank you.
Julie, I'd like to ask you, in expectation settings, which I think is so important, one of the things you stated was talking about reality testing future plans. Would you expand on that? I do that a lot with clients, and I'd like to hear what your perspective is. What do you actually mean by reality testing?
So it can cover a lot of different areas. So so I can give you some examples. But what that means is, once we've gathered all the information and we feel like we're pretty confident about what we know might be driving certain elements of change. So I'll use an example actually. My lived experience is that cervical spine issues actually there's a lot of discovery that I'm finding in adults who are in their 40s, 50s, 60s and beyond who are starting to develop real problems with cervical spine issues that totally fly under the radar screen. So this would be somebody who maybe is labeled as behavioral because they're just sitting on the floor, they're refusing to get up, they're walking differently, they're looking grouchier, now they're wetting themselves and they're doing that to punish us, like that kind of attitude about, right. And then being able to drill down further, try and unpack that issue, understand whether or not there is truly like a central problem that's underlying that. Or understanding what might be going into that kind of main headline of like, I'm concerned about XYZ behavior. And then with that information, we're trying to understand, say from a functional standpoint, what is this individual, like for expectation setting, what is this individual's functional prognosis now? Is this just the way they walk all the time? Well, no, now that we have this information, maybe now that we have some new diagnosis where we've seen a specialist, now these are the options and this is what the expectation might be. So that's the way I think about things like reality test or expectation setting is you really need to be informed by the information you've gathered and understanding what the root cause is for why certain things are looking different. So then you have enough information to say, maybe without surgical repair, for example, this is what we could expect. And if that's the case, now this individual might potentially be wheelchair dependent. And so what would that look like in his charming 3-story Victorian group home that he's lived in for the past 20 years? That's the kind of reality testing and expectation setting, right? About what the practical application is of the information that we just obtained, right? A lot of it comes down to when we're talking about memory, and especially if somebody does start to meet criteria for a dementia diagnosis, then how do we reality test whatever an individual's care support plan might have been, 25 years ago when we were just sort of anticipating what it would look like to grow older and that, I want him to remain in the family home forever, et cetera. But now that we're at a fork in the road where we have pretty good confidence around a diagnosis that is predictive of always being dynamic and changing and progressing in a way that we need ongoing more and more supports and more resources around us, how do we reality test that? And how do we do it in a way so that we're using as much information that we have to not, our crystal ball is not in the clearest focus, but it's not a total unknown abyss. We know that certain things are going to progress, so how do we anticipate for that so we can do things proactively and kind of future plan now as opposed to waiting for a crisis to be our starting line for making some additional plans.
That's perfect. I can't help thinking about the 80-year-old mother.
Yeah.
That's perfect.
Yeah, that's a real example.
I know
multiple times.
Example.
Yes.
The gentleman in the front row, please.
Dr. Neumeyer, I have a question and a comment. You talked about the Autism Care Questionnaire developed at MGH. Is that only in-house for your specific hospital, or can we access that in some way so that when we go to another situation that we would have that?
So when you fill out the questionnaire, it gives you the option to print immediately. And so we always recommend print it, so you've got a copy of it, and then it goes into a database at Mass General.
Okay.
But you get a copy to print. And yeah, and that information you can take wherever.
Okay.
And we want people to take it with them
Okay.
elsewhere.
And the comment I have is praise for the Lurie Center, because I have a 37-year-old son who started losing his language around 6, and then by the age of 9 had no language at all, and he was diagnosed by Dr. Isabel Rappin in New York as Landau-Kleffner and autism. And of course at that young age it was always using the Mayer Johnson pictures in a book and so forth. But through the Lurie Center he was evaluated and was able to acquire a NovaChat 10, which has the pictures, the Mayer Johnson pictures on it, but it also has voice output. And the best thing about it was that it was paid through Mass Health. They deny it at the beginning, but it takes perseverance and you can get it. So it has been a life-changing for him, because he feels so proud when he can actually get his thoughts across without having a voice for himself.
Thank you for sharing that story, that's
So-
great. Yeah.
In the back?
Yeah, I actually have two questions. On your autism questionnaire, it's kind of like a recommendation. The recommendation I just have is there any possible way you can maybe suggest that to go to DDS? It's not just for autism, for general, anyone that has a developmental disability, we filled out for whenever somebody goes into a hospital, for individuals who don't speak in general, so they don't have issues with nursing, so you can go out with them. Because I've had individuals that don't have autism, that just can't speak, or just nursing has hard times with them in general.
Right.
And that's just a suggestion that would make it easier for everybody, for nursing and doctors and everything. And I just want to say, I have another question, since you, both doctors are very knowledgeable. Since Dr. Feingold passed away, you're talking about geneticists. He was working with one of my individuals, and he passed away. He was a geneticist. How do you find another adult geneticist to work with individuals who have this specific genetic disability? I can't find an adult geneticist. They referred him to Dr. Finke, and Dr. Finke closed his practice, so now I don't have an adult geneticist.
I would say, look where you live. So if you live closer to Worcester, I'd go to UMass.
I've looked throughout the whole state. There is not, all I can find is adult geneticists for children.
Well, so most geneticists come through with pediatric training, but just like
Dr. Santoro.
Dr. Santoro, she's pediatric trained, but she cares for adults now. And the genetics training is not pediatric specific. Their first part of their training may be in pediatrics or internal medicine, but it really doesn't matter. So, for example, I care for adults, even though I trained first in pediatrics and then in neurology. But the neurology training was good enough, so I can care for adults as well. So you can go anywhere. So what I would do is, if you know the syndrome that your child has, often syndromes have family organizations, look and see if there's a doctor in the Boston area or in Massachusetts who is an advisor or is recommended by that syndrome group, and go to that person. Even if they're at Children's Hospital or where they typically just care for children, because you probably can get them in with a geneticist there.
Okay, thank you.
Any other questions? Yes, Beth.
Hi.
I've tried to look for research on this and haven't found much, but is there, clinically, do you see any indication of the relationship between Alzheimer or any kind of dementia and autism as people age?
You may see that more than me.
Well, I'll say this, I felt very validated to hear you say about the dearth of information about aging and autism, because it's a literature search that I do periodically, and still feel disappointed with what I turn up. So I have not seen anything out there specifically linking the two. And I think that's why in any approach to somebody with concerns around memory, we want to make sure that we're really approaching it as carefully as possible. There's no known, I don't have any basis to suggest that there's a known link. So our index of suspicion about dementia, sort of a progressive memory disorder, is something that I always want to make sure that we're really, it's best to approach every question like that with a healthy amount of skepticism, because a lot of times things that are sometimes misrepresented as looking different, and people start to get worried about dementia all across the board, for somebody who's 38 years old versus somebody who's, in their 60s, whatever. And the diagnostic challenge about dementia is that it's a diagnosis of both inclusion and exclusion, meaning you want to be hearing enough symptoms that sound suggestive of a progressive memory disorder, and you also want to be excluding all other plausible explanations about, and that's the real work, is trying to say, is this sleep apnea, do we have hypothyroidism, are we very depressed, are we grieving, that kind of ticking off that whole level of things. So that's the challenge. And the other challenge too, on the flip side, is that dementia can be the great explainer of everything. So if you really have yourself already sold on this idea that you're observing dementia, then that can all of a sudden explain why somebody's walking differently, why somebody's all of a sudden incontinent. So we really have to be careful around that. So sorry, I kind of went off on my soapbox on that topic, but just to get to your point, nothing that links those two together.
Carrie Mahoney to the front desk, please. Carrie Mahoney to the front desk, please.
Isn't it also true, I'm just jumping in here because my mother's has Alzheimer's and as did my grandmother before her, but isn't it also true that there's no way to conclusively diagnose Alzheimer's until after the patient has passed away?
Right, so that would be, a brain biopsy would be the final definitive gold standard diagnosis, which of course is just, maybe for research purposes or something. But there's enough clinical symptoms to hang our hat on, but you really want to make sure that you're being pretty adherent to the portion of, and this is what gets to that idea of change, is that the key criteria for dementia is that we're showing decline in domains, say more than 2 memory domains, compared to an individual's baseline. And that's the real bugaboo for our folks, because it's not, you can't make a presumption that you're seeing an MIT professor in astrophysics, and now all of a sudden that individual can find their way home at night or something. You already have made enough proper assumptions about that individual's baseline that the fact that they can't find their way home at night is frightening and alarming. But for anybody else, I think that's a lot of the work that needs to be done, is in what ways are things different from your baseline? And then really doing the work about excluding all those other coexisting conditions, of which there are many. And even if addressing and treating all of those other coexisting conditions don't totally reverse the concerns you're seeing, it at least is doing everything you can to move the needle, deflecting back towards improvement, that you actually have some action steps that you can take.
Thank you. I did want to say one other thing. So you're here for medical issues, but as you hear in the conversation and the questions that are being asked, the medical issues have to do with caregiver issues, they have to do with medical proxy, they have to do with guardianship, they have to do with living situations, they have to do with passing on the story, so that they intersect at many places. And so I just want to say, and as an employee of the ARC of Massachusetts, I'm going to tell you just real quickly about our program, but we have women, we have people, but they all happen to be women, who can help you connect those with a person-centered plan, who can gather the family together and say, let's talk about all of these things and how they connect and move forward. So I'm going to ask you to stand up. Christine and Evelyn, I know, but Evelyn and Barbara and Paula and Karen. So, And a lot of agencies, am I missing any of our support brokers? But a lot of agencies have these people with them who can help you sit down, plan for the future, but in planning for the future, connect all the dots that inform the medical care. So, and in the spring, we're doing another forum that touches on some of the other aspects of this, but this medical piece is just fabulous.